I think Dr. Ibrahim, he was on 2 seconds ago.
And great to see you, Shireen.
Lovely to see you, Roberta. Where are you connecting from?
I'm connecting from London today.
Excellent.
I'm on my way home to see my children from Italy, and I stopped by to see a daughter here.
Lovely. Sounds lovely. Safe travels, huh?
Thank you.
Okay. I think we'd be ready to start as soon as Dr. Ibrahim joins us. I'll just check. Excellent. Well, I think we're all on board, ready to start, Dr. Ibrahim?
Yes, I am ready to start, and welcome, Roberta. It's great
Thank
to see
you,
you.
Ibrahim. It's so great to see you and the colleagues at ERF. Thank you, Dr. Vishai. Nice to meet you.
Excellent. Well, let me start then. A warm welcome to our speakers, panelists, and participants. This is a very special seminar for us, for ERF and the World Bank. It's a fantastic opportunity that we'd like to share with you the latest MENA economic update, which is a twice yearly forecast that looks into the growth prospects for the region. This edition is particularly timely as we actually look into it's actually titled Overconfident, How Economic and Health Fault Lines Left the Middle East and North Africa Ill-Prepared to Face COVID-19, a concern that we all have. This edition in particular provides a stark assessment of the preparedness of the MENA public health systems and really the preparedness in terms of handling the pandemic, and it actually suggests a number of policy recommendations. I'm particularly honored and pleased that this very special panel will be sort of introduced by Dr. Ibrahim Al-Badawi, Managing Director, Economic Research Forum, Dr. Roberta Gazzi, Chief Economist, MENA Region, World Bank, and the report will be presented by Rachel, representing the different perspectives of a host of fantastic authors. And we'd have a fantastic opportunity to get some good reflections and insights from Her Excellency, Dr. Sarah Hassanein, with a policy reflection, and then followed by Professor David Bechet, looking into the preparedness of the region in particular, and finally with Dr. Amira Shell looking into both a mix of the policy and the academic perspective. We have a rich agenda. I just want to bring your kind attention that this session will be recorded and is broadcasted live on the ERF YouTube channel. We'll be providing all the details as we proceed, and during the presentations and the lead commentators' interventions, you're all welcome to put in your questions in either the Q&A section or raise hand for the floor in due course. With that, I give the floor to Dr. Ibrahim Al-Badawi to start the session.
Many thanks, Shireen, for this nice introduction, and also on your behalf and the rest of us at the ERF would like to welcome Roberta and her colleagues, and to really extend our thanks and appreciation for the opportunity to host this very important report and very timely one, and also for the opportunity really to have a distinguished panelists, the presenters, Rachel, and also the commentators, Her Excellency Dr. Sarah Hassanein and Dr. David Bishai and Dr. Amira Shal. I would like to say that actually this report is important and timely because a few years back we talked about the emerging new normal as a result of the financial and economic crisis of 2008. And that actually economic shocks and especially financial shocks intertwined with macroeconomic shocks and consequences are likely to be the new normal and its impact on economies the world over. Unfortunately, COVID actually made that kind of shock, that experience back in 2008, like a school picnic, as they sometimes say. It constituted a much significant and much more impactful shock. So I think the new normal now is dominated by shocks such as the COVID-19, and economies and policymakers and research communities and social society at large need to be prepared for these kind of shocks. And I think the report by the World Bank, would send a very important signal that actually complacency is the worst enemy of economies and societies. And I think the three fundamental issues that they pointed out, fiscal myopia, and lack of economic reforms, in addition to epidemiological trends and the conditions related to communicable and non-communicable disease, and essentially the issue of public health, which the debate on public health, which I think David has made, has kind of stressed that, including in terms of civil society. And then, of course, the illusion that could be created by, the demographics of high fertility and young population, that the region is relatively immune to the vagaries of health shocks such as COVID-19 or any other kind of pandemics and epidemics. So I think this is definitely a very important signal that we need to bring home. And then, of course, I would say that the three commentators, my reading of what they would say, David actually sent us, a commentary in which he emphasized the importance of debate on public health issues, in particular, and that there is a role for civil society. I think this is really very important and very complementary to the message of the report, including, of course, the suggestions that he introduced in terms of the methodology for assessing, the aspects of complacency or illusion. And Amira Shal actually have co-authored a very important paper, which actually we're very pleased to have published it as a working paper together with Professor Mahmoud Muhiddin and Imam Mustafa, which emphasizes the importance of macro-institutional aspects and the robustness of these institutions in order to mitigate or at least kind of minimize the impact of pandemics like COVID-19, especially with regard to kind of social indicators such as the mortality of children or pregnant women. I think these are very important aspects that I think will be brought home in the context of Amira's comments. The last and not least, and it's very, very important experience that I didn't talk to Sarah, but both Sarah and myself were policymakers at the time when the pandemic struck our home country, Sudan. And I think the experience of the lockdown and the cooperation between the Ministry of Health and the Ministry of Finance has been, in my opinion, despite the fact that the government then was just assuming power after a major revolution that changed a regime that persisted for 30 years, a kleptocratic regime that destroyed the institutions and had to deal with multiple transitions. I thought that experience perhaps merit consideration because it showed the importance of the lockdown that was imposed early on, and then also the cooperation within the government between the two key ministries of health and finance. So I think hopefully we will be addressing these issues and listening to the kind of the commentary and the feedback. And I really look forward to a very insightful, and I hope that we will follow this in terms of cooperation between the Chief Economist Office of the MENA World Bank and the ERF to further address these issues in a much more kind of grassroots approach, so to speak, by our researchers in the region, as well as, of course, the colleagues from the World Bank. So thank you very much, and I turn over the floor to you, Shireen.
Thank you. Thank you, Dr. Ibrahim. And with that, I give the floor to Roberta. Roberta, please, the floor is yours.
Thank you, Dr. Shireen, and thank you, Dr. Ibrahim and the whole ERF for the kind hospitality and this opportunity to discuss our work and to get different perspectives on what we do for the MENA economic update. In my remarks, I would like just to focus on three things. First, I will try to frame the regional update in the broader picture that we see happening in the economy right now with the pandemic in the world. The second, I'll give just a quick sense of what type of report we're talking about. As Dr. Ibrahim said, this is a semi-annual update, so it has a unique nature in terms of a report. And then I'll just highlight some of the top line messages that we get from the report, and then my colleague Richard Fan, on behalf of the whole team, will present them in much more detail. So Dr. Ibrahim was referring back to the 2008 crisis, and I don't know whether we can call any crisis a walk in the park, but we can definitely say that the pandemic that we see now is a crisis that is unique in terms of how synchronized it is across the world. And this synchronization has brought about essentially a rollback of many of the development gains that have been had in the past 10 years. So we know that this shock has been regressive on many fronts. Think about within countries. The initial lockdowns, which were the sort of initial cause of the largest economic cost, have affected the most vulnerable, women, youth, informal urban workers, who were both the most affected directly because they tend to be employed in face-to-face activities. They tend to be the most difficult to reach with, at times, with social protection programs. And often the most vulnerable are also the ones who have lower capital and lower human capital. And human capital is the one asset that is often essential to bounce back from crises. Now, this shock played out to be regressive also across countries. So in the first 2 decades of the 2000s, we know that we had a decline in poverty, but it turns out that 2020 marked the first year of poverty increase after consistent decreases since 1998. And again, in the past decade, we had seen a narrowing of inequality between countries, admittedly mostly due to the growth in China and East Asia and the Pacific, and now we see a reversal. And building on some work of our chief economist, Carmen Reinert, she did some of the math, and it turns out that in advanced economies, 41% have already bounced back to levels of GDP per capita pre-crisis, but that percent is 27% for mixed countries and 23% for mixed countries. So we see these vast gaps building, already widening up within countries and across countries. Actually, just one statistics for all, in 2020, 90% of the 196 countries had a decline in GDP. And that's a share that surpasses World War I, the Great Depression, and World War II, and the crisis in the 80s. We already talked about the increase in the global poverty since 1998, but something that is also of concern looking forward are the large fiscal deficits that have emerged globally. Some countries were already arriving with the buildup of high fiscal deficits and high debt. And I'm thinking about some of our countries, particularly oil importing countries in the region. But deficits and debt had a jump in 2020 because of the need to respond and mitigate the impact of the pandemic. Also, we know that inflation is worldwide picking up, and the debate, I'm sure that you followed, is whether this is going to be a temporary phenomenon or whether this is going to be a permanent phenomenon that will anchor new expectations. What I spoke about so far is a sort of short-term picture of the impact of the pandemics globally, but we cannot think about the global picture without thinking about the long-lasting consequences. And Dr. Ibrahim already alluded to some of them. Of course, on health, not only the human lives lost, but also the impact on functional health looking forward for those who had COVID, and the impact on education and building up of human capital for the generations of children that are in school right now. So for us as economists, there's lots to think about. Now, let me come back home to our semi-annual update. This report has a very unique structure. It is produced twice a year, so with a very tight production schedule, and it composes of two parts. The first part is a macroeconomic forecast, which is released before the annual and spring meetings, respectively, of the World Bank and IMF. And the second part is a part of a topic of interest. And to be frank, when we started to think in this juncture, we started to think about health, it was very difficult to think about anything else. So we decided to think about the connection between the economy and health. And having been also a microeconomist in my past, I have to say that the studies that showed causal impact of health on productivity used to be far in between for economists. It seemed to be a natural link, but it was very difficult to prove. This link between health and the economy is now staring us in the face. The angle that we took was not an angle of an evaluation of how the region did in facing the pandemics, but it was sort of trying to open the door on the question of preparedness of health system to face this pandemic and looking forward to potentially be ready and prepared for new shocks that we know, unfortunately, will come. So with that in mind, I just wanted to highlight some of the top messages that we have in the report. Rachel will tell you more about what we call a tenuous and uneven recovery across the region, and that's the macro part. On the health part, thinking about health systems, we sort of look back to the past 10 years, and what we saw were socioeconomic trends that came together to bring the region to be unprepared, and we claim also in the title, overconfident about this preparedness on the eve of the pandemic. The buildup of debt and an over-reliance on a state-led driven model of development have basically crowded out funding of some of the core public health functions. And that's the economic part. And on the social part, a combination of demographic and epidemiological trends have made it so that although the region is young, and that's a tremendous asset of the region, it is relatively more unwell than other regions. So the morbidity is high under a number of indicators, indicating that there is demand and potential for overburdening of systems. Then come COVID, and that was really a stress test. We conclude with an assessment of the fact that looking at different measures, it appeared that the authorities were not aware of the lack of preparedness of their systems on the eve of the pandemic. No country got it right. No country did it perfectly. This was a shock that threw the whole world askew. But what we can say is that even the most basic measures and numbers that are necessary to manage a pandemic and even to inform the public are often not collected in our countries. And if they are collected, they are not made public. So we conclude with a strong message on data transparency. But before I ruin the suspense, let me turn to my colleague, Rachel, who will actually go through our reasoning, our findings, and we look forward to your comments and ideas. So thank you very much again for having us.
Thank you, Dr. Roberta. And the floor is yours, Rachel, for more on the stress tests and the results.
Thank you very much. I hope you can all see my slides. Thank you very much again, Ibrahim and the ERF, for having us here, for organizing and hosting this event, and for connecting us to distinguished discussants. We're really here to learn. And thank you, Roberta, for the very kind introduction. Good morning, good afternoon, and good evening, everyone. Thank you for everyone who joins us today and for your interest in our report. This is my great honor and pleasure to be here to present to you our semi-annual flagship report, MENA Economic Update, October 2021. It is titled Overconfident, How Economic and Health Fault Lines Left the Middle East and North Africa Ill-Prepared to Face COVID. This report is produced under the leadership of our chief economist, Roberta Getty, whom you just met, and intellectual guidance from Daniel Letterman, the deputy chief economist, who is also with us today. I'm also proud to have as co-authors Arian Hetafi, a senior health specialist and a medical doctor. He is also with us today. And Ha Min Nguyen, a senior economist in our office. Anya Saltman, a research economist. Joseph Martin Sachs, a master candidate, and Christina Wood, a senior economist in our office. This report couldn't be done without extremely hard work from each and every one of them. So let me go through the roadmap with you. We will start with the macroeconomic forecast, which will show a tenuous and uneven economic recovery in 2021. Followed by long-term socio-economic trends that left MENA with overburdened public health system. And then we will talk about ill-prepared and overconfident health systems prior to COVID-19, which resulted in overwhelmed health systems during COVID-19. And in the end, we will talk about data transparency and policy recommendations. So to start with, the World Bank forecast that the region's GDP contracted by 3.8% in 2020, and we expect it to grow by 2.8% in 2021. We show the development in GDP in terms of GDP levels, as you can see in the solid black line on the left-hand side chart. Built upon the negative GDP growth of 2020 for MENA, even with the positive growth of 2.8%, MENA would still be below its 2019 GDP level by 1.1 percentage points. As you can see in that black solid line starts at 1 in 2019 and couldn't rebound to the horizontal line of 1 as of 2021. As a rough approximate of the economic loss from the pandemic, we compare the latest forecast, which is the World Bank forecast October 2021, with the latest forecast vintage conducted before the pandemic that was conducted in October 2019, during which we have forecasted consecutive positive growth more than 2% for both years 2020 and 2021. So based on that forecast, we depicted what the GDP levels would have been in a no pandemic scenario in the dotted black line in the left-hand side chart. As you can see, this dotted black line starts in 1 in 2019 and climbed above 1.05 at 2021, indicating a more than 5% increase in GDP levels compared to 2019. The difference between the GDP level in 2021 in the pandemic scenario and in the no pandemic scenario, which was conducted in October 2019, could be our approximate of the economic loss due to the pandemic. It's around 7% of the 2019 GDP, which is almost $200 billion USD. If we decompose MENA region by country groups, we can depict GDP growth for each group on chart on the right-hand side. As you can see, red lines represent GCC countries, orange lines represent developing oil exporters, and blue lines represent developing oil importers. GDP growth for 2021 is forecasted at 2.6% for the GCC and 3.2% for developing oil exporters and 2.8% for oil importing countries. The distance between the dotted lines and solid lines indicate that all three groups will suffer economic loss compared to the GDP level they could have reached in a no-pandemic world. That being said, what we care most is the level of GDP per capita. Compared to GDP, GDP per capita is arguably a more precise measure of the region's standard of living. Since the population in the region also grew by 1.6% in 2020 and 1.7% in 2021, the growth in GDP per capita is smaller than the growth for GDP. Based on the most recent forecast, the region's GDP per capita is forecasted to grow by a mild 1.1% this year, after a contraction of 5.4% last year. As you can see from the solid dark line on the left-hand side chart, compared to 2019 income level, which is shown as the horizontal line of 1, the region's income level in 2021 is still 4.3% below. And similar as before, we depicted the forecasted GDP per capita level in no pandemic scenario in the dotted line on the left-hand side chart, which is based on forecast of GDP per capita conducted in October 2019, the latest forecast before the pandemic. Compare the end of the solid line and the end of the dotted line, we see the economic consequences to per capita income level amounts to around 7%, which will be reflected in an increase of the poverty rate. If we zoom into the three country groups, the level of GDP per capita is depicted in the chart on the right-hand side. For year 2021, the growth in GDP per capita is forecast at 0.3% for the GCC, 1.6% for developing oil exporters, and 1.2% for oil importing countries. None of the three country groups would recover to income level back in 2019, which is shown as the horizontal line of 1. If we compare the distance between the dotted lines and the solid lines with matching color, we can see that the cost to the income level is 8 percentage points for GCC, 3% for developing oil exporters, and almost 9 percentage points for developing oil importing countries. Across countries, the growth rate of GDP per capita in 2021 will also be uneven, ranging from negative 9.8% in Lebanon, which is in deep recession, to 4.0% in Morocco. During this unprecedented pandemic, we believe that testing capacity is a crucial part of the health surveillance that is essential to disease prevention and response, at least at the beginning of the pandemic. This figure shows the negative partial correlation between COVID positivity rates and the macroeconomic costs of the pandemic in 2020, proxied by the difference between pre-pandemic growth forecast and the current estimates of GDP growth rates for 2020. The MENA region underwent incomplete economic, demographic, and epidemiological transitions before pandemic happens. Economically, lackluster economic reforms in the decade prior to COVID left a legacy of large public sectors and high public debt that effectively crowded out investment in social services such as public health. And this is called fiscal myopia in our report. Despite the need to transition to market economies, the public sector's role instead expanded in MENA after 2011. To document the region's truncated economic transition, we use government expenditure as a share of total GDP as the proxy indicator to represent the size of the public sector's economic footprint. As you can see on the left-hand side chart, MENA is the only one of the world's regions where government expenditure as a share of GDP grew substantially from 2009 to 2019. And on the right-hand side chart shows that in MENA, spending on health is overshadowed by large public sector wage bills. For all MENA countries with available data, the ratios of government health expenditure to public health expenditure are below those of other countries with similar income. MENA countries, as shown in red dots, almost all below the linear trend line with negative residuals, meaning they had low public expenditure in health relative to expenditure in public employment compared to countries that share the same income level. For example, the ratio of government health expenditure to its wage bill is 0.23 for Saudi Arabia, while a typical country with a similar income level, say Finland, has a much higher ratio on government health expenditure compared to wage expenditure. The ratio would be 0.57. What matters even more is how well money is spent. Yet the data show that fewer resources are devoted to preventive health and building a health system. Data for 65 countries, including 3 in MENA, as shown in the red dots on both charts, we can see that preventive healthcare expenditure as a share of general government expenditure in these 3 MENA countries is lower than the other income peers in the sample, implied by the negative residuals from the linear trend line. On the right-hand side, you can see that spending is also lower for government administrative healthcare expenditure as a percentage of general government expenditure. The lack of budget flexibility prevents governments from assuming the costs of providing healthcare and shifts health spending to patients who must pay out of pockets. Out-of-pocket spending, which we call OOPS, accounts for a major portion of health spending in many middle-income and low-income MENA countries, as you can see on the charts. Demographically, before the pandemic happens, all GCC countries except for UAE and more than half of non-GCC countries had higher fertility rates than their income peers in 2019. Data from UN World Population Prospects show that the fertility rate dynamics in many countries of the region changed from years of continued declines to a sudden increase in the late 2000s and early 2010s. This rising or atypically high fertility rates generated a youth population bulge that masked the region's comparatively poor health. The rising in number of youth in MENA during the 10 years before the pandemic created a statistical illusion of a healthy population. MENA's death from NCD's non-communicable diseases per 100,000 people are shown in 2 charts here. The left-hand side chart plots NCD deaths per 100,000 people against GDP per capita in 2009, and the right-hand side chart have only one difference. It's that the NCD deaths per 100,000 population after age standardization, which assumes that age groups have the same representation in all countries of the world. Age standardization is critical for comparing NCD burdens across countries because NCDs are not uniformly distributed across age groups. In panel A, it appears that MENA countries had fewer deaths from NCDs than did their peers in 2019, but it is a statistical illusion due entirely to the age composition effect. In panel B, after adjusting for age of the population, almost all MENA countries have a greater than expected number of deaths from NCDs. To further explore MENA countries' pre-COVID-19 pandemic preparedness, the analysis in this report relies on data from 2 existing indices of health security robustness. The first is the Global Health Security Index, GHSI, is conducted by objective external evaluators. And the second relies on a self-reported assessment by individual countries, the State Parties Self-Assessment Annual Reporting Tool. We call it SPAR. To construct a resilience framework for MENA countries, the GHSI data and SPAR data are adapted to provide a metric of MENA's public health system's ability to absorb a shock prior to 2020. The 4 pillars derived from those indicators are surveillance capacities, information sharing, health system capacity, and regular planning and readiness exercise. So each country's scores are then econometrically benchmarked against other countries at similar levels of development by regressing against its own GDP per capita and retrieve the residuals. Numbers in panel A show deviations from predicted values, that is, the residuals normalized by standard deviations using GHSI data. Cells are then color-coded to show deviations within, below, or above 33% confidence interval in yellow. And then, similarly, numbers in panel B show color-coded standard deviations from predictions using SPAR data. The difference from the 2 deviations results in overconfidence index in panel C. Cells in panel C are color-coded redder for a higher overconfidence index and greener for a lower or more negative confidence index. So let's take a look at the result. In panel A, of the 19 MENA countries across 4 areas of preparedness, MENA countries' GHSI data consistently underperformed their income level benchmarks. Every country except Jordan has at least 1 pillar in which it underperformed peers, and only Jordan and Morocco have 3 pillars in which they outperformed peers. In panel B, by contrast, only 6 of 15 countries gave themselves low enough ratings to show that they were underperforming. In panel C, the table also documents the region's tendency toward overconfidence by showing the differences between the objective assessment and the self-assessments of the region's public health system preparedness. In 41 out of 60 cells here, MENA countries displayed overconfidence in 41 of them. COVID-19 is more like a stress test to their health system. Admittedly, the stress test triggered by the pandemic has not yet produced firm conclusions on the resilience of health system. However, it seems clear that the limited resilience of the healthcare workforce and the supply of medical products and technologies have already caused critical bottlenecks. The WHO Pulse survey found that 53% of the WHO Eastern Mediterranean Regional Office countries reported disruptions in the delivery of healthcare service because not enough staff were available. How to measure this overwhelmed health system? One widely considered objective indicator of deaths caused by COVID-19 is the excess mortality, the number of deaths from all causes above the expected number of deaths during a specific period. All-cause mortality includes reported COVID deaths, unknown or unreported COVID deaths, and other deaths, whether from disease, accidents, or something else. The excess mortality measure has long been used to estimate the death toll of pandemics and other extreme events. So our figure on the left-hand side shows rising excess mortality in selected MENA countries. Most, if not all, of the excess mortality is believed to be the result of the pandemic. And how much is this measure of excess mortality compared to countries' reported COVID death? Karlinski and Kovac use excess mortality as a proxy of death from COVID, particularly for countries whose official data of COVID is incomplete, and they use this ratio to calculate the undercount ratio, which you can see on the right-hand side. A high undercount ratio implies that unknown and unreported COVID deaths and other deaths were missed. Our table presents the undercount ratios for 6 MENA countries with available data. Both the overconfident assessment of health system preparedness and the uncounted COVID deaths reveal lack of data transparency in MENA for public health. This is why we're suggesting data transparency for public health is beneficial. Building resilient and effective health systems in MENA is a comprehensive task. Yet what is common across MENA countries is the lack of reliable, high-quality digital data to inform transparent and accountable decision-making. So we try to document the difficulty of finding and accessing commonly used indicators to assess pandemic response of countries in the region. We researched the availability of 9 indicators related to COVID-19 across 18 MENA countries. The selected indicators provide basic information about key aspects of public health and about the conditions facing frontline health workers during the pandemic. This figure shows the availability of indicators by country. And this figure shows availability across countries for each indicator. The data were found to be publicly available only about half of the time in MENA. Sometimes data were collected but not publicly available. And in many cases, it was not possible to make the decision whether the data was or was not available. This shows that even if data is collected, it is often difficult to find and access. To sum up, we learned that MENA countries were overconfident about preparedness of their public health systems relative to peers and objective assessment. And prior to the pandemic, 3 long-term trends undermined growth and made MENA ill-prepared for health system shocks. Economically, large public sectors crowd out of investment in social services such as healthcare. Demographically, high fertility rates affected dependency ratios and created a young population. Epidemiologically, high incidence of non-communicable diseases is worrisome as well. And COVID as a stress test had shown the weakness and ill-preparedness, and it has also illustrated the relevance and benefits of data system. As policy implications, we're here to promote improved availability and use of data, which will facilitate appropriate planning and preparedness for regular and emergency healthcare. Thank you very much.
Thank you very much, Rachel. This was really, really intriguing. I would immediately give the floor to Her Excellency, Dr. Sarah Hassanein. Dr. Sarah Hassanein, former Acting Minister of Health in Sudan. She's a public health expert with over 15 years of experience in health systems, strengthening and program management. She served as Undersecretary of Federal Ministry of Health and Acting Minister of Health in Sudan in 2019. Previous to that, she was the Global Fund Project Management Unit and Head for the Malaria and Resilient Health System Program. She was also lead consultant with a number of international organizations, and she would share with us her reflections to the report. Dr. Sarah, the floor is yours.
Distinguished authors and participants, I congratulate ERF and World Bank for organizing this platform to launch this important report. I see this report as a provision of invaluable findings that trigger several hypotheses that needs further testing and investigation, and really can give a platform for several research and mixed method research projects, actually. I can see that the strongest component of this report is the flagged question on how certain we are about our health system responsiveness and resilience to the uncertainty, no matter what. This can actually, and if answered in a very quantifiable and objective manner, this can give a benchmark for countries in order to move forward in building strong and resilient health systems. It's quite clear and apparent also from the findings of the report that the whole public health jurisdiction and health system should not and cannot actually be read in isolation from the political and economic trajectory of the countries and also within the whole region. And it's also quite clear that the epoch of the COVID-19 shock as an example for an uncertainty and an emergency and the prevailing political unrest in MENA region and elsewhere, for example, and the associated economic and social events can really impact health. And I think this is really an important intersect that we should all, by the end of this discussion, highlight and actually kind of promote for and advocate for. From the report, you can see clearly that studying and looking for the political ruling models and the instability is so essential. For example, if we're going to look into more underlying factors for this long-standing fragility, let's say, and ill-preparedness of the health system in the region, all this needs looking into the ruling models and the instability and the overall development and ruling and the unclear overall development and ruling programs. Because this can further impose gaps, data abandon, and also can impose weak and vulnerable systems. For example, also the fiscal myopia, which can really be used as an indicator in itself, when and a reflection for the prioritization gap, let's say, within the authority and the decision-making, let's say, cabinets. For example, looking into the short-term wins or prioritize the short-term wins can really augment the fiscal myopia, and this can also be more augmented by any kind of instability within political instability within the country or the region. So we can see that the principles of the universal health coverage, the health security, and the health determinants should be looked at in a very comprehensive and integrated manner. And still, these principles are still valid because also one of the strengths of the report is looking into the long span data of 10 years, which is also a reflection of how the preparedness were really a hassle in the region. So what we can point out is that universal health coverage, the health security and the determinants of health, and other, let's say, comprehensive factors should be tackled in an integrated manner, and also even even the assessment should look into the whole picture, and even the pathways of technical supports and the pathways of the financial support as well, and the financial expenditure, so that we come up with reliable and context-specific solutions. For the epidemiological transition and the demographic dividends, which is looking into it with the disruptive interventions as well, and many of them are universal health coverage links, such as the essential services, and the vaccination per se, which is going to trigger as well these public health issues, or let's say these macro issues as well, which puts us in a position where we cannot move forward without looking into health policies, legislation, and looking to the positive balance of trades. For example, the gaps that were there in the PPEs and the essential medicines, and of course some of the vital medicines as well, it highlights a real challenge among most of the countries that certain looking into data for the forecasting and quantification is essential, and also assessing, let's say, and reviewing some of the legislations and the policies in line with the power relations within the country itself and the local context. For example, the essential medicine there was some countries has been facing challenges in the price. There was a flare even before the COVID-19, and also there was scarcity, let's say 6 years before the COVID shock, and the COVID shock made it even worse. This from here we can say this is one of the essential and the vital priorities for the low and middle income countries, and also for the region, for the countries of the region, to look into more of the how to improve the data in order to come into efficient to realistic forecasting and quantification in a way that where they can really cater for the emergencies and any shocks that can come, and also to look into any potential local. Some countries, of course, in the MENA region, they're already way ahead in the local medicine manufacturing. But also, this is an area where, let's say, strengthening and support should really be thought of, which can also lead into sufficiency, and how to balance this positive kind of getting to the positive balance of trade. More or less looking into the positive, to the diagnostic part, which is also should be looked into in a very holistic manner, which is has been a real challenge as well for many countries regarding the COVID, but we can see it also in other communicable and, by the way, non-communicable diagnostic elements. So the global diplomacy and the diplomacy should work to promote for collective identity, which is I really can see coming from this also report, where we need to promote not just for the diagnostic, but the diagnostic that really work specifically for the poor, and to look into beyond the cost effectiveness and to balance it out within the market force. And it has been quite clear that the data and information system infrastructure might be a real challenge, and also let's say the utilization of the timely utilization of the data, as well as let's say the data culture itself might be something challenging, and also this should be read with the governance structure as well, which is, as I've mentioned earlier, should be read with the overall political model as well, to ensure that the governance is well strengthened, the transparency itself, and to ensure that we monitor, evaluate, and learn as well. The data should be a comprehensive package covering the vitals, the demographic, and the integrated health information system. When we also look into the kind of findings that has been highlighted by the report, like the epidemiological transition and the limited workforce as well, the demographic dividends, which also can be augmented here and there and interlinked. This is also a necessity of tackling all levels of the health sectors at a micro to optimize the access and to ensure that the local community needs are really well met. And also at the meso, through strengthening the resilience and the capacity. And I'm happy that the second comment will be more or less looking into the workforce in a very, let's say, rigorous manner. And also at the macro level to consolidate the resilience and also the response within other sectors, like what Dr. Ibrahim mentioned. The main lesson that came from the cooperation between different governments and different sectors in this kind of shock really needs multi-sectorial and interdisciplinary responses. And it really needs imposing a highest bar of comprehensive set of indicators that sufficiently look into and read the common good for health, and also the other externalities, especially that one of the points is the high death tolls of the NCDs, and also the emerging or the increase in the non-communicable disease, where several commercial determinants of health should also be tackled, which usually align with a lot of legislation and policy changes as well. Also, we should be looking at the inclusiveness and the community center and health system interventions, which is also can easily be picked up from the findings of the report. Even in the prioritization, given the limited physical space that the countries might be facing, the prioritization could be conducted and could take place through thinking of the externalities of any kind of interventions. For example, in a more simple way, not limiting the intervention to certain or let's say short-sighted kind of ways. And also, more or less, it's quite clear that the field-informed mixed method research projects are really need to be ongoing in this COVID-19 sector, that we have an informed decision-making that really looks into the local community, the gender mainstreaming, the refugees, and the voting by food, which is also a way how the local communities would give their voice. And this is also important when we need to tackle epidemiological transitions and demographic dividends, because as we all know, the risk factors per se for the NCDs really affect disproportionately the vulnerables, and disproportionately also there is a differential in the genders, and also refugees and so on should be well in our agenda. This could all be built on through these findings from this report, and also building up through using health system and policy researches, and also integrating the monitoring, learning, evaluating, and learning aspects. Thank you, and with that, I thank you once again for convening discussions, and looking forward to the application of multi-sectorial reliable solutions.
Thank you, Dr. Sarah, ever so much, and thank you for making the time and persisting with the connectivity to join us. Before we open the floor to questions and answers, I'd like very much to welcome our two other lead commentators, Dr. David Bechet. Please, you have the floor, Dr. David, and perhaps just one introduction. Dr. David Bechet is professor at Johns Hopkins University. His areas of interest are very much around health economics, population economics, family economics, and he's got fantastic expertise with the Johns Hopkins School of Public Health as president-elect of Faculty Senate, and prior to that as director, Interdepartmental Health Economics Program. Dr. Bechet, the floor is yours.
Thank you. Can you hear me and can you see my slides?
We can see the slides and hear you. Perfect.
I'm also speaking to you as somebody who just spent the last 10 months on a sabbatical working as a local public health officer. And I wanted to just make sure everybody on this webinar is aware of a semantic trip up that is very common. It's common to get confused with the three words public health services, because there is a whole profession called public health. And public health is a specialty, and it's different from public health services. So this is very important, because a lot of what went wrong with COVID was obviously public health services, but it was a deficiency in public health as a profession. Public health is a commodity. Public health can be defined as what we do to assure the conditions in which people can be healthy. This profession is 200 years old. It was actually started by Jeremy Bentham, who thought that it should be the responsibility of governments to create the utility of a community. This is a profession that solves public goods problems. It solves collective goods problems as described by Eleanor Ostrom, by creating trust and norms of reciprocity. So when we speak about problems, there's both is there fiscal space for health services, but what are we doing about this profession, and do we have it? It's organized in a hierarchical level on the planetary basis, WHO, regional EMRO, ministers of health. But what I think we need to speak about in the MENA region is the deficiency in local public health, because that is a problem that is something to be overconfident about. We see our local health departments in MENA. There are buildings, there are people, but they are not practicing public health by and large. The people in the regional and local health departments are primarily offering clinical services. And the reason I can prove to you that local matters is any map of COVID anywhere in the world. This happens to be Iran. If local didn't matter, you wouldn't see local boundaries. It would all be one rate for the country. It's not. All of COVID, our bodies are small and the virus gets into us locally around us, and the enforcement of safer environments is done by a local health department with public health practice. So this is an area of overconfidence that is so important. And if we simply pour money at a regional or national level, we're missing the problem of the workforce. The workforce of local health departments has to locally assess the local health threats. Where are the mask violations? Where are the obstacles to vaccines? Using that locally. You're not going to get that from a region or a nation. Then the local partnerships. When I worked as a health officer, I had to know my principals of the schools. I had to know all the private doctors, the faith community, commerce. I had to have them face to face. Eleanor Ostrom's problems are coming from trust, and the local health department has to do this, but if they're not trained in public health and they're simply running clinics, they won't do that. So a local health department is scaled for that trust building to coordinate participatory coordinated approaches. The citizen engagement with their local health department can build the trust to overcome vaccine hesitancy. Throughout the MENA region, the preconditions for this specialty of public health are not present. This profession has been starved. The schools of public health are not generally leading into careers in this workforce. People who work in a health department in a MENA region are often very clinically oriented, spending maybe 1 or 2 years in a public health post, hoping to get a specialty appointment in an urban area and then make the big money. So they're not committed to careers as public health practitioners. And the other issue that is global is that we don't trust our local public health providers to find their own solutions. There's been a top-down dictation of solutions to the workforce. Finally, there's a lack of a local constituency. That local health department doesn't have a mandate. The citizens aren't engaged in knowing that that's what they need. So from a local public health department, this weakness, what is the thing that has allowed COVID around the world is a weakness in local health departments. So if we simply say, as the World Bank often does, more money, well, yeah, more money, but we have to invest it in not the same cadre of public health workers. We certainly do need doctors and nurses and pharmacists, but what we really needed forever was people who know this profession of public health. And if you just simply build an IT system and lots of data exchange and lots of computers, again, if you don't have a workforce to handle it, it's not going to work better. Planning exercises is suggested by a lot of, let's get prepared and do planning exercises. Again, not useful without this profession. So my recommendations coming off of this report are to invest in the profession of public health. It's a specialty. It needs to be invested in, and it's going to take a long time. These local health departments make us overconfident. They're not up to task. We have some checklists for them, but we need to give them to the people so that they can improve their performance and normalize the expectation that the public health departments of the MENA region will be working to make communities more livable. So it's a long commitment, but it's worth it. Already there are examples in the region that could serve as horizontal learning opportunities. And there are schools of public health that are there ready, but they're not fully connected as the the area where we're going to get a pipeline of workers. These careers are not funded. People don't go into public health and stay in it by and large. They go in it and they leave it because it's not been institutionalized. So examples of regional areas, there's an Institute for Primary Care that just started in Libya last year. About 5 years ago, we started an International Institute for Primary Healthcare in Addis, which is close by. And again, if we look around COVID, there's so many very, very skilled countries that did a tremendous job with handling COVID vaccines. You could look at the Gulf, at the Emirates and Qatar. Let's look at their examples. What did they do right, and spread those examples. So I really want to thank you for inviting me. Congratulations to the authors of this very important report.
Thank you very much, Professor Bichet. That was really insightful. I'll go straight to our final lead commentator, Dr. Amira Shell. Dr. Amira is Senior Policy Manager, JPAL, Middle East and North Africa. She is where she leads policy partnerships for evidence generation, dissemination, and use in social protection sector. And she's also Assistant Professor of Economics at the Faculty of Economics and Political Science of Cairo University. Amira, you have the floor.
Thank you so much, Dr. Shireen, and I'm really glad that I've been given the opportunity to to go through such interesting report, and which I personally find very interesting, intriguing, and timely. And I like the most thing that I like about the report is the approach that we are not kind of evaluating and saying, okay, this went wrong, this went right, but again to try to have some lessons learned for the future, because at the end the trend is that health disasters or public health emergencies are on the rise. So we have to be honest with ourselves to stop and see what went right, what went wrong, and then to try to see how we can be perfectly prepared for future public health emergencies. And I would like to congratulate Roberta and her esteemed team for this very, very insightful report. Okay, I'll try to stick to the timeline. So basically, to give okay, 1 second. So to summarize the key findings of the report, first, the report provides evidence of a tenuous and uneven economic recovery across many countries in 2021 in the wake of the pandemic. And second, the report sheds light on the long-term socio-economic trends, specifically economic, demographic, and epidemiological uncompleted transitions over the past decade, which actually overburdened the public health systems. Third, the report suggests or concluded that MENA health systems have been ill-prepared to adequately absorb the COVID-19 shock, despite the optimistic views of the authorities about the preparedness of their health systems. And finally, and this is a very pertinent conclusion or suggestion by the report, is that weak data transparency and data systems has significantly contributed to the overconfident yet ill-prepared situation of the health system. I'm going to touch base upon some of the salient points by the report and like to share with you all my thoughts. So first, in the first and second chapters, the report sheds light on the tenuous and uneven economic recovery. And actually, the discussion is very, very interesting, very insightful, and it focuses on the impact of public health surveillance, and second, on the impact of rising commodity prices, and the impact of both factors certainly is very large. But again, my own sense or my own view is that other factors may be as significant, especially the pre-pandemic economic conditions, other than the market orientation policies that have been kind of emphasized by the discussion of the report. So take, for example, Egypt. We had like this market orientation before the Arab Spring, and there was the population, or we have heard people alleging that, okay, this strict or like kind of elevated market orientation has been the cause for the Arab Spring. And post the revolution, and as actually it has actually been highlighted by the report, there has been a shift to the state-centered model of development. And despite these despite these shifts to the state-centered policies, we have seen that Egypt, it was actually, as I recall, the only country that has been that had positive growth, growth figures even during the most serious stages of the pandemic. So again, my own sense, or my initial thinking is that, okay, public health surveillance is critical to economic recovery. The rising commodity prices again is very critical to the path of economic recovery and to the heterogeneity we are observing when studying different countries. But my own sense that we cannot focus on this as the only or the sole contributors to the economic disrecovery, if I may call it. And the case of Egypt maybe kind of sheds light on this. It has been, the model now is state-centered, but it was the only country that has actually had positive growth figures during the pandemic. Also, other factors can be significant to the recovery path, including debt stabilization, unemployment levels, which are currently elevating in the region. So maybe these other factors can kind of complement the analysis undertaken by the report public health surveillance and rising commodity prices. And this actually brings us to the second point that has been raised by the report, which is the serious implications of truncated economic transitions on economic growth. And again, a need to transition to market economies is emphasized in the report's chapters. My own sense again is that our problem or our issue in the region is a problem of the lack of accumulation of knowledge. The region has witnessed short, interrupted reform episodes, leading to interrupted growth and human development episodes, especially if we are talking about middle-income MENA countries. So the idea for me is like we can have this transition to market economies, but usually it's like a short phased one, it's interrupted. And again, maybe because the trickle down effect of the economic benefits of transition to market economies is not evident to the population, this actually leads us to something like the Arab Spring. And again, we shift to a state-centered model of development. So maybe we can have a kind of a comprehensive analysis focusing on the deep-rooted issues of the region, and which in this sense we can also highlight structural transformation in the broader sense, which is, for me, it's indispensable to achieve economic preparedness, fiscal space, etc. The discussion of fiscal myopia was for me is very super interesting, and I was very much happy to see this bold discussion of the governments and how they are making decisions during the pandemic, and to see that actually this fiscal myopia has left MENA countries ill-prepared for pandemic, hurting recovery. And to have this in the report was very much appreciated, and to find that other people are stating this, because at the end, we all know that governments usually find it more convenient to focus on spending that has short-term effects rather than long-term social gains. And this is actually we call it in the kitchen of governments the quick wins strategy. So usually we politicians tend to focus on quick wins because this is what would be appreciated by the population. And again, we have related to this, we have the discussion by the report on public employment and how this public employment is high or is increasing. In parallel, we see that public spending on health is low at a time when overall public spending is growing. And but the thing is that the report makes like a kind of a conclusion, or like that this has been causal. Public employment has been kind of driving investments out of the public sector, but I don't think that the relation between both is very much evident. For me, I cannot say that like increasing public employment basically led to a decline in public spending on health. Maybe I don't think maybe this warrants further investigation on the causal pathway between public employment, the wage bill basically, and public spending on health in MENA countries. Moving to the next chapter, focusing on demographic and epidemiological transitions, it was super useful to me to have this like complete picture of what's going on in MENA, because usually reports focus on the economic aspect of like the economic conditions during the pandemic, or the health aspects or the health conditions during the pandemic. So it was super useful for me to read the report chapters talking or tackling transitions and seeing how these maltransitions actually have accompanied truncated economic transitions in the region. Also, the discussion of overconfidence of MENA public health authorities was very much interesting and intriguing. And like the idea itself of trying to compare between the public health, the objective preparedness, versus the self-assessments, which basically are provided by health authorities, was very much interesting and very much useful, which can be like used later in further investigations. But my own sense that MENA governments or MENA public health authorities, they actually recognize that they are not very well prepared. Even if they are not very much like technical, they know that, okay, what's the percentage of GDP spent on health? We all know this figure. It's a basic figure. Even non-health economists have can translate this figure. So I think, or my own sense, it is that public health authorities know that they are not well prepared. They cannot convene this when they are asked. Surely, I cannot, if I'm a government, in the government, I cannot say explicitly, no, we are not prepared well, because I know that I have like this awareness of the low public health spending. I can see the image from the kitchen, but again, I can't convey it to the public, or I can't convey it in the self-assessments. So maybe this explains the disparities between the objective and the subjective assessments of preparedness. And actually another relevant point here is the low familiarity with public health emergencies in the region. Set aside MERS, like many MENA countries have not like experienced a lot of like public health emergencies or health disasters. So I think this maybe also can be insightful for the analysis of overconfidence. Another critical issue that has been covered by the report is the health system governance and and the way it has to go. And this is actually very, very important. And to me, I know that this is not the main contribution of the report, but for me, this is the main issue that we are facing at the MENA region. It's the governance issues, it's the political will issues. We have the resources, and we know even if we don't have the financial resources at hand, we know how to mobilize our resources. But the thing is that with weak governance systems, we cannot even efficiently use our resources. We don't apply cost effectiveness study to see how we can invest efficiently in our healthcare systems, etc. So I think this this discussion in the report should be highlighted. It's very, very important that the governance failures, including lack of transparency, accountability, are of paramount importance. And this has actually been evident in the COVID-19 era. Other failures, such as the low trust in public health authorities, have also significant impact on the availability or the ability of authorities to induce behavior change during public health emergencies. And there is like vast amount of literature tackling this point, how risk communication can be used, especially at the early phases of a public health emergency, how risk communication can be used in limited resource settings in order to control the negative impacts of public health emergencies. And again, the impact of risk communication would basically depend on trust in public health authorities, which will bring us again to the important discussion on governance. Finally, the report highlights the ill preparedness of healthcare systems of MENA using the Global Health Security Index, and this is kind of a heat map for global health security worldwide, and it shows that MENA is the second least prepared region after sub-Saharan Africa, and we all know that the stronger the preparedness of healthcare systems, the weaker the negative impact of public health emergencies. But again, I want to highlight, and maybe this slide is consistent with what Her Excellency Dr. Sarah has highlighted, that public health emergency management, surveillance, response, preparedness, risk communication, etc. Yes, they play a significant role in controlling disaster effects, but other factors can have greater impact, namely health emergency finance, universal health coverage, education, gender equality, and WASH coverage. And this has there is growing evidence on this, and this was the project we were currently the paper we published with the ERF, and which Professor Ibrahim El-Badr referred to, that preparedness should be when we talk about preparedness, we should talk about it, we'd better talk about it in its broader sense, creating universal healthcare systems, improving female education, preventing breakdowns in infrastructure, and specifically failures of basic hygiene, sanitation, and running water systems. So preparedness is a notion that is not just the health security index can explain or can reveal, but my own sense and based on my own research, preparedness is a very, very wide notion. And actually our results shows that universal health coverage and WASH have more significant impacts during health disasters than public health emergency management. So I think it would be very beneficial to have this holistic view of preparedness. And finally, so we all know the big picture, that the new norm is the occurrence of weather, health disasters. This is actually the new norm the MENA region is facing, the whole world is facing. So preparedness, be it economic preparedness, health system preparedness, etc., is not a luxury anymore. The question now, and which we can build upon the analysis of the report and try to take this further, is how can the MENA region be well prepared to meet future public health emergencies? Totally, I agree that big data and the availability of data is one key issue. But again, I don't want to overemphasize the impact of data versus, for example, the impact of governance, the impact of political will in the region. So basically, we can conclude that collaborative action is needed. So this is my last slide, and then actually, when I was going through the report, I found a lot of prospects for future investigation. So maybe in future, to face future health disasters, can adopting a smart approach to community healthcare behavior change be a game changer in low and middle income country MENA, specifically in low income settings? And also, how can we expedite MENA adoption of digital health technologies? This is a point that has been raised in the report, and I think we should take it further through our research. And again, what are the best approaches to strengthen the governance component of public health system management? And another point that is not very much related to health economics, but maybe it could be more relevant to doctors. What can explain the incomplete epidemiological transition? So we are still facing high burden of communicable diseases as well as non-communicable diseases. What can explain this, and how can the MENA region fight this? And finally, how to incentivize broad but intentional data collection and the transparent dissemination of data to improve our response to future public health emergencies. Thank you very much, and thank you mostly for giving me the opportunity to discuss this very useful piece of work. Thank you.
Thank you very much. Thank you very much, Amira. We've only got a few minutes left, so I would very much like to give the floor back to Rachel and perhaps also to Roberta to react to some of the comments we've heard from our lead panelists. And there was also a question in the Q&A session where I think Roberta attempted a response to that. So with that, in the interest of time, I give the floor back to Rachel and Roberta.
Thank you, Shireen, and thank you so much to Dr. Hassanin, Professor Bishai, and Dr. Elshel. It's a real honor to hear these very insightful and comprehensive suggestions to not only our future research, but also to our global practice teams in the field. We learned a lot. For the sake of time, let me yield the floor to Roberta. Thank you.
Thank you, Rachel, but thank you.
Can we hear Roberta?
I can't hear her myself.
Daniel, perhaps you can come in. You're on mute, Daniel. Oh, yes, now we got you. We got Roberta back.
Yeah.
Roberta, we had lost you. Roberta?
Sorry, our chief economist. Oh, there she is. Okay.
Oh, I'm back. Well, thank you, Danielle. And I'll pass it on to you. My internet connection is a bit unstable, but I was just saying, it's difficult to say something interesting when you actually agree with the points that your discussants make. So let me just try to highlight something that really spoke to me about how to take this agenda forward. And it might not be us in the Chief Economist Office, but I hope it's going to be the team that works on health in the bank, the researchers who works on health in the bank. One thing that I wanted to say is that what we tried to do here was to connect the macro picture with the health picture in a way that would raise the visibility of the importance of building health systems and of importance of thinking about public health in the very sense that Professor Bishai was saying. By no means we claim that we offer solutions or policy suggestions even, because our lens is very partial and limited here. But things that really spoke to me from what the discussants have said include, first of all, the fact that the importance of the local level versus the central level. And in a way, we try to get at it by indicating that there is an overimportance and excessively heavy footprint of the state, parenthesis, of the centralized government, and an underplay of the local conditions, including through the use of data and information that could build a grassroots ownership of being better and improving through accountability services. Second, I like the sort of sobering message of the reality check that Professor Bishai gave us on the importance of investing in the profession of public health in a way that gives the right incentives for people to enter the professions and the appropriate funding and incentives. And we didn't mean to have this conversation about money only. And if that's what comes across from the report, we need to go back to the language that we use, but really to give the incentives for people to grow and learn from each other and learn from great examples. I like very much what Her Excellency, Dr. Hassanin, told us about the importance of a multi-sectoral response that brings together the importance of access, the importance of resilience, and the importance of accountability, with a special attention for those groups who are particularly vulnerable, women and refugees. We haven't mentioned that, but this is something that is very important and very pertinent for our region. I could see that Dr. Elshal is a microeconomist at heart, because she was saying, I don't see the causal path. Did you really prove the causal path? And we didn't. Full disclosure, we didn't prove that causally a larger wage bill is associated with underfunding of core public health functions. And here I'm trying to use the public in public health in the correct way, as Dr. Bishai was saying. We didn't prove that. However, I would say that there is strong circumstantial evidence that in a development model that relies a lot on the footprint of the state to keep a social contract alive, the public goods that are invested most from the government are the privatizable public goods. Those are public employment, those are cash transfer. And there is a less of an investment on the true core public goods that are valuable for everyone, but that cannot be privatized in the sort of quid pro quo, to use a Latin and very much used Italian expression, between the citizen and the government. So let me stop here and also turn to Dr. Lederman, who has been a core author of this report and for sure would like to react to these great comments. But I just want to conclude with heartfelt thank you for the thinking, for the enthusiasm, and really with the hope that this is a conversation that started here, but it is to be continued with the Chief Economist Office of the World Bank and across the great researchers who are part of the ERF network.
Thank you, Roberta, colleagues. Thank you very much to the hosts, to the real experts, Professor Bishai, Dr. El Shal, and Dr. Sarah. We learned much. Let me just tackle a couple of comments that just popped up from our executive directors at the board of the World Bank Group. Just a technical clarification, almost every exercise that we do empirically compares MENA countries to countries of the same level of development. So I invite our ED officers to read the report. Number two, we are in the report, in the macroeconomic section, have a brief discussion on commodity prices, oil prices, and their disparate effects depending on how exposed an economy is. And there's no time now to go into the technical details. Happy to answer any questions from our board of directors going forward by email or otherwise. And Dr. Bishai, a special warm thank you to you. You've been at the front line here in the United States, at the front lines of where politics meets public health functions. And even in one of the best prepared countries in the world, the outcomes have not been that great because of the political polarization that invaded and contaminated the public health functions, even in the United States. So thank you, Dr. Bishai, for your service, and Dr. Sarah for your service as well. And Amira, we look very much forward to hooking up with you guys at JPAL MENA. Thank you so much. I'm very much looking forward to future conversation.
Thank you, Daniel. Thanks ever so much. We had Dr. El Azhari raise hand, but I think got disconnected or signed off. But the comment is there in the chat, so we'll be sharing this with Rachel and give now the final word to Dr. Ibrahim for closing this very, very rich session with a very warm thanks to each and everyone. It's been really, really delightful to put together this session. So thank you. And Dr. Ibrahim, the floor is yours.
Thank you. Thank you all. I think we all learned a lot from this fascinating and very spirited conversation that we have had. And thanks really to the authors of the report themselves who allowed us to have this wonderful conversation, and also the contributions of David, Amira, and Her Excellency Sarah. And I think this is really great, and I'm quite happy and grateful as ERF for the opportunity to host such an interesting report. I have just two quick kind of parting comments I wanted to make. I think, thinking about including, for example, the slide that Amira showed about the health shocks and the dominance of health shocks, thinking ahead in the future, it's very clear that the concept or the development agenda or discussion about universal, social protection, including health coverage, is such an important topic that certainly is going to be very relevant for the kind of development discourse in the future. And so the political economy of how could we motivate governments actually to give high priority to this, I think would be a very important dimension as well. I think Roberta stressed the linkages between macro institutions, macro policy, such as, for example, creating the right fiscal space, enough fiscal space to provide for social protection and universal health coverage and so on. But I think the political economy, such as, somehow motivating the public to trust the government in order actually to commit to paying taxes, for example, because there is a huge disconnect between what the public really want and their ability, or not ability, but their willingness actually to pay taxes, so that governments, because they don't really trust government. The barometer, the African barometer and the Arab barometer all suggest that there is a deep mistrust of governments as custodian of the resources and the commitment to share the resources. So I think a political economy aspects would be very important to consider on this. And I think Sarah have alluded to this, in fact, not only alluded, but discussed this in greater detail in her comments. Finally, going back to memory, of course, I am an old hand. So back in 2000, when Alan Gelb was the chief economist of the Africa region, we did a very interesting report. I was the task manager. And the title of the report was quite intriguing and optimistic. The title was, "Can Africa Claim the 21st Century?" And Jeffrey Sachs then was at Harvard School of Government. So he invited us to give, to present the report. And I think he made a very insightful comment, especially for the case of Africa. He said that Africa has never benefited from the Green Revolution because of the tropical and arid and semi-arid nature of the agroclimatic zones in Africa. And then second, because of the very heavy burden of disease, the tropical kind of disease ecology and so on. And so he actually said that the World Bank should really consider building a scientific agenda with a core of scientists as part of the staff of the World Bank. And perhaps this report reminded me that actually, of course, the World Bank will always be dominated by economists. But perhaps maybe this is a thought that you might want to think about for the future skill base of the World Bank, given the dominance of disease and public health issues. So without further ado, let me just thank you again, and looking forward to continuing the conversation in the near future.
Daniel, thank you very much.
Thank you. Thank you all.
Sure.
Thank you.